What do I want? عين يمين وشمال شو مكتوب عليها؟ شو مكتوب عليها؟
Hello, Dr. Tabea.
Hello, John.
How are you doing?
I'm fine. How are you?
Good. It's a little early here.
It's all right, no problem.
We'll wait a few minutes, okay?
Sure.
Yeah, the way you gave those questions in the Kahoot was good.
So you like them, huh?
Well, yeah, it was easy for me to do.
Yes.
Because you made them short, you know?
Sure.
It's a little early here.
It's all right, no problem.
Let me get, I'm sorry, let me get off. Yeah, the way you gave those questions in the Kahoot was good.
So you like them, huh?
Well, yeah, it was easy for me to do. Yes. Because you made them short, you know? Sure. Let me look. That's recorded. That's recorded. I can't get it out. There we go. I was recording the same thing.
Yeah.
Yeah. That's recorded. So how you been?
Well, busy as usual. Next week we will have a webinar with Kika Turell about complications of neurosurgery. So I will skip next week and then we'll continue after that.
Oh, okay. That's next Wednesday. Kiki's
I can't remember. It's not Wednesday. I think
November
it's
5th. Oh, excuse me. It's March 5th, right?
it's something like this. Yeah.
I'm trying to televise that.
Super. Yeah. It's
Yeah,
good.
yeah. I'm trying to because we just televised a webinar on AI and how it can help artificial intelligence, how it can help complications.
Absolutely. Yes.
So he wrote me, Kiki wrote me, he says, can that the PhD from Buffalo give a presentation? I said, yeah, great. I'm waiting to hear back from Kiki about that.
Sure.
I would love to have him give a presentation, because this artificial intelligence guy, it's a really good connection, because he's at an American school, and of course you can be part of it too.
Surely.
They need about 9 or 10 centers around the world to assimilate data, obviously.
Yeah.
Obviously, and so that's why he asked me, because I've done a webinar with him before with 3D printing and neurosurgery, but he's now into artificial intelligence.
Yeah.
He says, can I give a webinar? So yeah, give it 3. So he gave 3. And guess what? Who was at the first one? The 2 best people in the world. Ben, right?
Yes.
From China.
Yeah.
Who says, oh, great, I want to collaborate with you. That's a home run right there.
Absolutely.
Yeah, from China to be able to hook up with one of the biggest neurosurgeons in China.
Absolutely.
To try to incorporate AI, and that was a fantastic break.
Excellent, excellent.
And also at the conference was the leading neurosurgeon from Beijing. Right. Was there too at the webcast.
Yeah, yeah.
And this can work, I think, if we can put the ends together.
Absolutely.
Tie them together.
Yeah, yeah.
So you of course you're welcome. I'll give
you
his address and everything.
Surely, no problem.
The PhD, and you can say you're interested in participating. They're looking for collaborators. He told me he's looking for collaborators. So we got a bunch of more people coming in here.
Sure.
Let's see here. Yeah, we can wait a few minutes. Yeah, I mean, to be able to collaborate with Chinese artificial intelligence, oh, that'll be fantastic.
A connection with China and whatever aspect and whatever title is very important.
Yes, in today's world.
Yes.
In today's world, and it's possible. It's possible. Tomorrow we're televising Dr. Lawton and Dr. Krish with that micro neurosurgery webcast.
Yes.
And we're televising to China too with WeChat. So we expect a big crowd tomorrow.
Absolutely.
Can you come by?
I'm not sure, but
it's at 6 o'clock. Well, it's a bad time for you.
It's bad.
Time. Unfortunately, they know it's a bad time.
Yeah.
It's at 6 o'clock in Arkansas, which in Jordan, that's ridiculous. 1 or 2 in the morning. Yeah.
2 a.m. 2 a.m.
Yeah. So but they knew that.
Sure.
So they're going to adjust. They're going to do more.
Sure.
Okay, you want to start?
I'm happy to start.
You ready?
Yeah.
Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good day, this is Dr. John Bennett, broadcasting from Miami Beach. We have another Jordan Neurosurgical Grand Rounds. Dr. Sabeh has been doing these online for a while, a couple of years now. And he did teach before in person for 27 years, right?
Sure.
Almost weekly webinars incorporating multidisciplines, which is different His webcasts are different from some because he incorporates other specialists. Anyways, welcome, Dr. Sabea. It's all yours.
Thank you very much indeed, John. Okay, so again, good morning, good afternoon, whatever time you have in your country. My name is Ibrahim Speyh. I'm a neurosurgeon from Jordan. I am broadcasting from the Farah Medical Campus in Amman, Jordan. Last week, we had a snowstorm. This is not an unusual event. We have snow every year in Jordan and in the Middle East in general, in the high plains. The difference between years is how many storms you have. Sometimes you get 5, 6 storms each lasting for a few days. Sometimes you get one. This one was the first this year, but it was very, very harsh. Roads were blocked because of the very heavy snow. People just wanted a break to get out and to walk their dogs or walk around and get something. This is from the front of my house with my car, and my daughter's car is covered with snow. This is the garden. This is where the swimming pool, which we evacuated during winter time. And these are my 2 daughters making this a very beautiful snowman. Again, I usually put to you this black iris, which is the symbol of Jordan. And today we will continue the past few weeks talking about the unusual intradural spinal lesions. I always put this slide, 508 cases of spinal intradural tumors. And today I'm going to speak about specifically about some kind of the schwannomas. All in all, I had 89 schwannomas, but schwannomas differ in their locations and so on. Today, I'm going to speak about intramedullary, intradural schwannomas. So let's speak in general about spinal schwannomas. Just going to the basics, the posterior root and posterior root ganglion, the anterior root, and the dural cover, the arachnoid cover, and it fuses here at the level of the ganglion. So this nerve roots and everything is in the subarachnoid space. Here it is extra-arachnoid space. So whenever a tumor develops from the neural tissue, from the Schwann cells that will form the schwannomas, it has a bearing on what we are seeing now. Sometimes you get the anterior root and posterior root separated. You have a space, like here, space between the anterior root and posterior root. Sometimes you don't. They are just stuck together like this. Again, this has an implication on where the schwannoma would develop. So back again, you get type 1, where there is a Schwann cells here. Type 2A and 2B, you can see, are arising here from the posterior root or rootlets. Here it is extending out, 2B. 3A is magnification of what we have said before, larger size, 3B, going intraspinal and extraspinal. So this could be the a combined intraspinal and extraspinal dumbbell-shaped schwannomas. And this is the classical dumbbell-shaped schwannoma, where it is extending in the neck or the lumbar area or whatever. So we're not going to talk about these usual classical schwannomas. We're going to talk about intramedullary schwannoma. And one would say, how come? How would one get an intramedullary schwannoma like this one? It's very rare to start with, 46 cases only reported in literature. And there is an explanation for that. The axons, which should be outside the spinal cord, could be displaced within the cord. Or the axons accompanying arteries inside the cord. Or there is an ectopic Schwann cells. So these 3 explanations of how you get a schwannoma, which should be extramedullary, you get it intramedullary. Again, this is to explain it. So these are the ventral roots, and these are the dorsal roots. So schwannomas arising from here are the usual classical schwannomas. But look here, inside the cord, sometimes you will find they are extending into the cord itself, and they would give the patient a schwannoma. So the first case presentation for this unusual spinal lesion is intramedullary schwannoma, and as usual, we'll discuss it from the clinical, radiological, operative, and pathological correlation. This is the case, 34-year-old man from Libya who came with this intramedullary tumor. You would call this astrocytoma, you would call it ependymoma, you would call it whatever you like, but this is an intramedullary lesion. There's no doubt about that. And here's some of the still pictures opening into the posterior sulcus. Again, stop using the word myelotomy. Nobody does myelotomies. You open the posterior sulcus and then find the tumor. And histopathology from our colleague, Dr. Hussam Abu Farsakh, fellow of American College of Pathologists, who've been cooperating for decades and decades. And he reported this. Antony A and Antony B areas where you have dense cells or loose cells. Antony A is dense and Antony B is loose. There are spindle cells arranged around blood vessels in a pseudo-rosette pattern, as you can see, blood vessel, and these are cells around it. Mitotic count was high for a benign schwannoma. It's 8 to 10 in high power field. Mitotic count should be 2 to 4 in benign tumors. When you go up to 8 and 10, you're getting into trouble. There may be some malignancy there or atypicality. And indeed, the Ki67 was 10%, it was high. So all in all, the immune staining showed S100 positive, epithelial membrane antigen weakly positive, Mymentin positive, GFAP negative, pancytokeratin negative, P53 is negative. So the final report from our colleague, Dr. Farsakh, the histopathologist, this is a schwannoma with atypical features. This is the post-op. You can see we have done a good job removing all of it. And you can see where we went in through the posterior sulcus. So there's no more tumor. And the good news is that the patient remained extremely well without any neurological deficits, because you did not do myelotomy, you did opening of the posterior sulcus. And the schwannoma is a benign tumor. It is well localized. You can find a good plane of cleavage. And we have shown few films in the past few weeks about how to open the posterior sulcus. And at the end of this series of spinal lesions, I will put some tips, surgical tips about how to do that, maybe in 2 weeks or 3 weeks' time. So this is a long-term follow-up of this patient, and there's no recurrence, although we were afraid that there may be some recurrence. The second case I'd like to discuss is a neuroenteric. Neuroenteric or enteric cyst. It's clinical, radiological, operative, and pathological correlation. If we look at the CNS cysts in general, there are two types. Either they are neuroectodermal or they are neuroendodermal. Neuroectodermal like ependymal cyst or choroid plexus cyst, and the neuroendodermal is like colloid, Rathke's, and the neuroenteric. So our topic is this, neuroenteric, which comes from a neuroendodermal tissue. How do we reach that point? Let's go back to the embryology. Third week of gestation, you have the amniotic sac, the yolk sac, and here in the middle you have 3 layers, the ectoderm, the endoderm in yellow, and in between is the mesoderm. This is the amniotic cavity, this is the yolk sac cavity. And here starting to develop is the notochordal plate. So same cut, inner here is the endoderm, here is the ectoderm, and this lid is the mesoderm. And some of these cells from the endoderm, they would migrate and persist in that location and give rise to these enteric or enterogenous cysts or neuroenteric cysts. So here you are, the neural plate, the mesoderm, the notochord, the neural crest come together to form the neural tube. Ectoderm remains outside, and here is the mesoderm, and here is the spinal ganglion. This is a beautiful picture showing the above, the embryology, the neural tube being developed, the notochord here, the intermediate and the lateral plates, and the endoderm. So if there is a failure of these separation between ectoderm and endoderm, and some endodermal cells find their way, the end result would be formation of these enterogenic cysts or neuroenteric cyst. They could be in the midline, they could be lateral. That's in the cranium. And an example of this is Rathke's pouch, where we have this pouch coming from the pharynx, this pouch coming from the brain, infundibular process, Rathke's pouch. They meet, and this Rathke's canal disappears. If it persists, then it may give rise to Rathke's cyst or craniopharyngioma or enterogenic cyst or neuroenteric cyst. So colloid cyst and Rathke's cyst and enterogenous or neuroenteric cyst are one and the same in terms of embryology formation. And the spine, again, remember the first picture we have seen, this is the amniotic cavity, this is the sac cavity, this is the ectoderm, this is the endoderm, here the mesoderm and the notochord would develop. So again, failure to separate the two would lead to this. So this is the skin, this is the spine, this is the bowel. You may find dorsal enteric fistula connecting it with the gut, GI tract, or like this, it is dorsally located, or here it would be inside the spinal cord. So a neuroenteric cyst is a lesion composed of basal membrane, and on this basal membrane there is an epithelium resembling GI tract or respiratory tract. Hence the name. People call it bronchogenic cyst. People call it GI cyst or neuroenteric from the word enteric, intestine. So here you are. You find a basal membrane resting on a fibrocartilaginous wall, and this sheets of epithelial cells making honeycomb appearance. And these cells could be pseudo-columnar, ciliated or non-ciliated. Again here, columnar, non-ciliated. The first one was ciliated. Ciliated columnar. And in between, you'll find lots of mucin-secreting goblet cells. So this is in relation, the cilia is related to the bronchogenic tract, and the mucin-secreting is related mostly to the GI tract. So sometimes you find the combination between pseudostratified columnar and goblet cells together. And Wilkins and Odom, they classify this cyst into type A, type B, type C. It's simple, we don't have to bother about it. Type A is a single layer pseudostratified. Type B is a complex invaginations. Type C is with ependymal and glial tissues. Most of the time we get type A. And they are cytokeratin positive, CEA positive, and S100 negative, vimentin negative. This is the immunohistochemistry of these enteric cyst, neuroenteric cyst. Let's look about history. Kobe and Fulton, they were the first to describe these neuroenteric cysts, and they call it wrongly teratomatous cyst because they could not give a name to it. That's back in 1928. Bishop from France, 1934, he called them intestinomas. So change from teratomas into intestinomas. While these two, Holm and Matson, they coined the term that we know nowadays, that is the neuroenteric cyst. So Kobe Fulton, 1928, this is their paper, teratomatous cyst of the spinal cord containing mucous and ciliated cells, published in the Surgical Gynecology Obstetric Journal, 1928. While Bishop from France, 1934, published this paper, Variety rare di teratome sodurale di la region cervicale, and he called them intestinomas. He published this in Revision Neurology back in 1934. And as I said, the coining of the term neuroenteric cyst came from these two gentlemen, Holm and Matson. So nowadays we recognize these as a neuroenteric cyst. Do they have other names? Yes, but the one accepted in literature, the one you should stick to, is a neuroenteric because it gives everything you want. It's related to the nervous system, it is related to the GI tract or respiratory tract. So call it enterogenous, endodermal, neuroendodermal, enteric, archenteric, bronchogenic, gastrogenous, epithelium. They are all correct terminology, but they are now obsolete. And the one that's still stuck in literature and used excessively is the neuroenteric cyst. Let's look about the confusion by the WHO. What should we call these lesions? Back in 1979, they said it is a cyst found by mucin-secreted epithelium resembling that of gastrointestinal or bronchial tract. Okay, we know this from 1923. So nothing new. In 1993, they said, oh, enterogenous cysts are classified as tumor-like lesions. So people, be careful, 1993, these are tumor-like lesions. In 2007, no, people, don't. These are not a tumor. And the last one in 2013, well, we'll be back to that this is a tumor-like. And as we go along in the presentation, you will see that it is a tumor-like. It behaves like a tumor. What is the age? Age is adults, 15, 30, 40 years, very rarely in infancy, but it can happen to anybody, but this is the common stage. Male to female, unfortunately, us males are more than females. Are they common? No, they are rare. In this paper by Emerson and his group in this journal, 2004, he just reported 4 cases in 26 years of his experience. A recent paper from the Toronto Hospital for Sick Children, which is a very famous place for sick children, over 30 years, they just had 11 cases. So they are rare. Why are we discussing rare things? Because they look like common things. And if you don't pay attention to that, you would fall into major troubles. If we open this cyst, what would we find? What are the contents of this of these cysts? Could be cranioid, could be mucoid, could be pus-like, it could be like CSF. This is from literature. This is the cyst, and it is very thin CSF-like cyst. Here it is mucoid, full of mucoid material. Here it looks like pus, and sometimes they smell because of the chronicity. They smell like odd, and you may think they are pus. That's why we are discussing these cases, because if we don't know that they do exist and that they do resemble so many other lesions, we would fall in trouble. So people, stop looking just at the common thing. You should master also the uncommon things, because they will come your way, and then you would fall into mistakes. And this is a creamy white lesions. How do they look like on images? In general, they can happen in the cranium or in the spinal cord, CNS, but here we'll look at it in general view. How would these cysts look like? The investigations one should do is CT, MRI, MRV. And CT, it could be hypo, it could be iso, but rarely calcification, if any, no calcification. MRI is more confusing. Look at this. T1 iso hyper, T2 iso hyper, flare is hyper. But the fact of the matter is this: signal on MRI depends on the protein concentration within the cyst. And as we have 4 types of protein content, whether CSF-like, creamy-like, pus-like, or whatever, so you'll have so much variability. And here is the source of confusion, source of mistakes if you don't pay attention. Do they usually have contrast? Contrast, no enhancement usually. Sometimes they have peripheral enhancement, and that's because they initiate some inflammatory changes around them. And most of the time they have no perifocal edema. Can you hear me, John?
Yes.
Okay.
Yes.
So this is a statement that is very useful. Whenever you suspect an neuroenteric cyst, MRI of the craniospinal axis should be performed. So if you find a lesion in the posterior fossa, go and have total spinal MRI. If you have a lesion in the thoracic area, go and have total spine and brain, because they do exist in both cranial and spinal. What about the images? What do we see when we look at the cranially located enteric images? First of all, let's decide this. Spinal is more than cranial. Spinal in neuroenteric cyst is far more than cranial. Only 80 intracranial cases reported, and mostly they are in the infratentorial. So infratentorial neuroenteric cyst is much more than the supratentorial ones. Let's look at the supratentorial ones. Look at this, how they look on T1 and how they look on T2 and flare. Very much confusing. Here there's no restriction on diffusion study. This is from Canada, supratentorial neuroenteric cyst, and they call it a fascinating entity of uncertain embryo-pathogenesis. Look at that. You can call these arachnoid, you can call it epidermoid, you can call them in the way you like. From USA, it is lateral supratentorial endodermal cysts. So not necessarily in the midline, they could be laterally displaced. Intracranial laterally placed supratentorial neuroenteric cyst. Again, this could be missed for arachnoid cyst. From Japan, this lateral convexity parietal lesion in neuroenteric cyst. Again, large laterally situated cysts. From India, and again, this is lateral extradural supratentorial cyst. So they could be subdural, they could be extradural, they could be intraparenchymal, but intraparenchymal brain and intraparenchymal spine is rare. This is a case presented with repeated hemorrhage, mimicking a brain abscess. So looking at this, you diagnose a brain abscess, and it's increasing. You give antibiotic, they give antibiotic, it's increasing. They had to open it, and it was because of the repeated hemorrhage. This is one way of their presentation. Their natural history is to increase in size, not to decrease in size, and they can have repeated hemorrhages, and they can have malignant change, and they can rupture and cause chemical meningitis. From India, this is cysts with some thing inside that is because of the contents of the cyst. Again, you can diagnose here an astrocytoma, especially if the patient is a child. This is from Atul Goel and his group. Cyst of the third ventricle. Cyst of the third ventricle, you can easily miss that as craniopharyngioma or arachnoid cyst or whatever, because it is there causing hydrocephalus. Cyst of the lateral ventricle and the septum lucidum. Again, you could say this is a colloid cyst. Again, why are we discussing rare cases? Because they resemble the common lesions, and we have to know them. You have to have a mental exercise every time you see a case, every time you have to exercise this mental exercise, otherwise you would fail. Craniospinal anterogenic cyst, again, sitting in the midline, in the area of the foramen of Monroe. They can occur in the orbit, anterogenic cyst. Again, here, is this a lymphoma, or this is what, or this is a meningioma, or optic nerve glioma, or whatever. So you can see presenting like a tumor, and it was just an enterogenous cyst. From USA, also this paper about this cyst were in the third nerve, on the oculomotor nerve, causing oculomotor palsy. And another case from Australia showing the same neuroenteric cyst at the site of the oculomotor nerve. There could be multiple supratentorial, infratentorial, like this. More to add to our confusion. This is from UK, from London. Let's look at these neuroenteric cysts in the infratentorial compartment. So there you are, it is infratentorial. They like to sit here in front of the brainstem. Look at here, bilateral, in front of the pons and the medulla. And no diffusion restriction. There is some contrast enhancement, which is unusual. Here we have good contrast enhancement. Again, this is unusual. So you can here diagnose so many things. You can say this is a vagal schwannoma. You can say this is Cordova, all kind of diagnoses. So in the posterior fossa, which is commoner than supratentorial, but less than spinal, the anterior to brainstem localization is 50%. So mostly it is anterior to brainstem, but it can occur in the fourth ventricle, can occur in the cerebellopontine angle, it can occur in the cervicomedullary area. So here you are. Look at this. You would diagnose this as what? Hemangioblastomas or what? So very unusual pathology from USA. From China, again, this tumor in front of the brainstem. The cranio-medullary cervicomedullary junction. Some part is extraparenchymal, some part is intraparenchymal, which is unusual. Again, in front of the brainstem, like this. These are histologically verified cases. These are not imagination, these are real cases, and they look like the cases we see every day in our practice. From Japan, again, this in front of the brainstem lesion. This is anterolateral, going laterally to the brainstem. From India, Atul group. Posterior fossa, massive enterogenous cyst. Posterior fossa in front of the brainstem with contrast enhancement, which is unusual. Atypical pathological findings, and this particular patient presented with chemical meningitis because it is full of the same material like you find in Rutgers, that you find in craniopharyngiomas, that you find in so many of these cases where there is high content of fat and cholesterol, and then they would cause chemical meningitis. And this is another enterogenous or neuroenteric cyst mimicking an intraaxial tumor of the medulla oblongata. Again, you may diagnose this as ependymoma, medulloblastoma, or astrocytoma. And this is CPA angle. Again, here you go into the differential diagnosis. The commonest is, of course, vestibular schwannoma, meningioma, epidermoid, and this neuroenteric cyst. This is totally extradural, posterior fossa extradural, which is unusual. This is another case of cerebellopontine angle lesion, CT and MRI. It could be dorsally located here, not in front of the brainstem, not in the fourth ventricle, but posteriorly located, like this. Again, you would not be criticized if you diagnose this as a medulloblastoma. Here it's just sitting underneath the tent. From Australia, from Japan, around and in the quadrigeminal cistern. And look at this surprise. neuroenteric cyst of the clivus. So there is a lesion in the clivus, extradural, inside the bone, and you would not call this as a chordoma. It is a neuroenteric cyst verified by histology. So when you see a lesion of the neuroenteric cyst of the cranium, you would have a very wide differential diagnosis. Don't miss that. It could look like epidermoid, dermoid, choroidal cyst, ependymal cyst, Rathke's pouch cyst, colloid cyst, parasitic cyst of all types, or even cystic tumors. There is some entity called cystic schwannoma, or cystic meningioma, or xanthoastrocytoma, metastasis, cystic metastasis. All this resemble these enterogenous cysts. Brain abscess, tuberculomas, dermoid, epidermoid, cholesterol granuloma, arachnoid. All this goes and fall into the differential diagnosis of these intracranial cysts. What is the treatment? And here we're concentrating on the cranial neuroenteric cyst. The treatment is surgery. And this beautiful paper from India, and the title is total excision of a spinal neuroenteric cyst possible? The answer is yes, it is possible, but not in all cases. Sometimes you have accept defeat because of the adhesions, because of the location that you leave part of the capsule. So all in all, you are aiming for radical excision. So gross total surgical excision is the treatment of choice, although it depends on the cyst location. So you may do marsupialization of the cyst, you may do a shunt of the cyst, and you can approach the cranial posterior, anterior, or lateral approach according to where the lesion is. Example of this, excision of the contents and the capsule, very thin wall, like this. Again here, this is the pre-pontine, pre-medullary cistern, neuroenteric cyst that has been removed via surgery from Tariq Tihan, USA and Canada. You may just leave a catheter inside the cyst, which is not a good option, but this is if you fail to achieve what you want by radical excision. Is there a place for radiotherapy and chemotherapy? None. So the only thing is surgery. Can they recur? Yes. They have high percentage of recurrence, ranges from 0 to 37%. It is more if you have intramedullary spinal cyst or intraparenchymal brain cyst, and we agreed that most of the cases are outside the parenchyma, but if they are inside with adhesions, then recurrence is high. And also if they have adherence to the neurovascular structures. And most important, in histology, if you have high proportion of goblet cells, expect high incidence of recurrence. Let's look at the papers showing recurrence. From Japan, this paper, where they excised and came back. Again, this from India. Removed, came back. From Hong Kong, removed, came back. From Bangladesh, intraventricular, removed, came back. So let's think of neuroenteric cyst as a tumor line. They behave like a tumor and we should treat them like a tumor. So although they are benign, slowly growing lesions, but there are reports of cysts. They have rapid expansion and most importantly, malignant transformation. They are transformed into papillary adenocarcinoma. That's why we have to remove them. Malignant transformation was reported in 9 cases. 6 cases in the brain, cranial, and 3 cases in the spine. This case from Japan, malignant change, mucinous adenocarcinoma arising from supratentorial intramedullary neuroenteric cyst. So this was parenchymal and came back again, and it was malignant. Cerebropontine angle that was removed and recurred back as malignant. This is the reason why we should insist on removing it and remove it in a gross total fashion. Intraepithelial carcinoma from a cyst of the posterior fossa, confirmed histologically, a malignant change. Neuroenteric cyst in the posterior fossa presenting with intracranial metastasis. So this is very malignant. Again, accession, recurrence in other places, seedling from China. As they present with increasing or fast growing lesions, they can bleed, as we have seen in the previous slides, because of the hemorrhage. So this is one of their presentation, hemorrhage into the cyst. And that takes us into a new sphere of thinking, hemorrhage into cranial and spinal lesions. Maybe it's gonna be one of the topics that we're gonna discuss in the coming weeks or months. Hemorrhage into CNS lesions. Now, give you a case presentation about cranial neuroenteric cyst. This is a 30-year-old male patient from Bahrain who came up with this cyst, which is in front of the medulla and the pons. And you can see it here, and you can see it here at the pontomedullary junction. This is the vertebral study, the MRA, MRV. And this is the patient before surgery, and we put him in the sitting position. And this is the surgery. So the patient is in the sitting position, and here is the beginning of surgery. We are trying to open the arachnoid that's covering the accessory nerve. This is the spinal accessory joining the cranial accessory. So opening the arachnoid and then proceed inside. This is the upper end of the dentate ligament that we liberated and cut so that we can have more space. And then you can see the edge of this region here, coming where the vagus nerve comes out from the medulla. So here you are, this is the lesion. More exposure by dissection, and then opening and sucking the contents out. Not enough, we have to remove the membrane, and we have to remove it completely. So you can see here the dura over the clivus. I want to remove every piece of it, and then I'm going to pay attention to the membrane. That's the membrane that was covering the cyst. So we remove it and send it for histology. And you can see here the vagus nerve being liberated, and this is the accessory nerve. Okay. So we have now discussed the enterogenic cyst of the cranium. And this is the histopathology from our colleague, Dr. Hassam Farsakh. He produced us beautiful slides showing what I've mentioned before, the pseudostratified ciliated membrane or epithelium sitting on the fibrovascular background. The goblet cells in between the columnar ciliated and columnar non-ciliated. These are the goblet cells by PS stain. This is the CEA, carcinogen membrane antigen. It is positive. Valine was positive. We don't spare any immunohistochemistry. Dr. Farsakh does not spare anything to reach the diagnosis, and I'm supporting him with that because we need to be scientific about it. This is the high molecular weight cytokeratin Cyto 5.6, Cyto 7, Cyto 19, P63, and this is the post-op. You can see that we have done a good job without any deficit to the patient. This is the patient immediate post-op, and this is when he came to the clinic, paying us goodbye to go back to his country. Now let's look at the spinal in neuroenteric cysts. As I said, the spinal is much more common than the cranial, but all in all, it's not that common in the spine. It's 1.3 of all spinal tumors, while in the cranium, it is 0.2 of all intracranial tumors. So spine to cranium is 3:1. Spine is more than cranium, cranium infratentorial more than supratentorial. We mentioned that already. And as I said, in the spine, 90% they are intradural extramedullary, inside the dura, outside the spinal cord. 5% only are intramedullary, and 5% are extradural. And in the spine, they are associated with so much anomalies, vertebral anomalies, spinal anomalies, visceral cysts, etc., etc. And they are commoner in this sequence, more in cervical than thoracic, more than lumbar, more than sacral. Examples: intradural, extramedullary, inside the dura, and it is, as you can see here, intradural, extramedullary, again here, intradural, intramedullary, inside the cord, which is rare, 5% only, but it is inside the cord, and it could be anywhere, in the midline or laterally or wherever. Again, another case of intramedullary. Paper, intramedullary neuroenteric cyst of the spine inside the conus. Intramedullary, various types, shapes, and forms. Intramedullary, again of the conus. Again, they may not have contrast, like this, no contrast. Same thing here, no contrast. Here, they have contrast. So it's so variable. That's why we have to discuss these cases. This is anterior to the spinal cord, that is extramedullary, intradural. This is mobile spinal cyst, something in intermittent paraplegia because it moves. The same cyst of the conus medullaris, presenting with lower limb pain. Oh, this is a disc prolapse. People think of backache going to one leg as disc prolapse until proven otherwise. This is wrong. But 10% of the causes of backache going to the limb could be not related to the disc disease or degeneration whatsoever. 5% of these cases are due to a tumor. So don't give patient a treatment for disc prolapse without defining the diagnosis that this is really what it is. It could be multiple, like in this patient, infant, multiple cysts. So in 50% of the spinal neuroenteric cysts, you have spinal anomalies. Now, you don't see this with the cranial. If you have a cranial enteric cyst, they're not associated with the spinal anomalies. But the spinal neuroenteric cysts are, in 50% of cases, associated with anomalies, scoliosis, vertebral anomalies, spina bifida, meningocele, dermal sinus, diastematomyelia, Klippel field syndrome, syringomyelia, etc. So spinal dystrophism, lipomeningocele, split cord, as we said, and they could be associated with GI tract malformation and cardiac malformation. Look at this, scoliosis. Look at this, dextrocardia. Look at this, Klippel field syndrome, fusion of the vertebrae together with short neck and the chromosomal changes. And this is the diastematomyelia with the split cord and associated with the cyst. So anomalies like this applies to the spinal cyst, but not to cranial cysts. And if you see one, you have also very wide differential diagnosis to make: ependymoma, astrocytoma, subependymoma, oligodendroglioma, interstitial cyst is still on your cards, epidermoid lipoma, schwannoma, as we have seen, ganglion neurocytoma, hemangioblastoma, cavernoma, multiple sclerosis, tuberculosis, and so on, lymphoma, and transverse myelitis. What is the treatment? Just the same like cranial. You need to do surgery. So surgery is the mainstay, and here is some of the cases: pre-op and post-op. Pre-op and post-op. You go posterior, and it is not myelotomy, it is posterior opening of the posterior sulcus. One of the cases, this is the cyst inside the cord. Again, before and after surgery. Before and after surgery. I've seen that. Here they have reported this case, which is very unusual. They went ventrally. They did ventral resection and anterior fusion, utilizing sternal notch exposure. Why? Because it was sitting anterior to the cord, so they went this way. This is one way to do it. Although most people would say posterior approach would be sufficient. You just cut the dentate ligament, you mobilize the cord, and you can get anterior to the cord. Again, anterior approach in this case. We've mentioned that already. A recurrent case after accession, as I said, it is not uncommon. Place for radiotherapy, chemotherapy, none. We presented cases in the cranial neuroenteric cyst. Let's see some of the spinal, and then we'll be finished. I just need 5 more minutes. First patient is a 21-year-old male patient from Jordan with a chronic backache since childhood, recent deterioration of power in his lower limbs. He exhibited pyramidal signs in his lower limbs, and his joint position since was impaired. And look at this, giant neuroenteric cyst in the lower cervical area. Look at this, just thin rim of cord tissue left. So we did surgery, and I'm going to show you surgery now. Here we are opening the dura. As I said, maybe in a few weeks' time, I will summarize the surgical tips and tricks that one uses, how to open the dura, what to do with the arachnoid, how to get into the cord, what are the landmarks, how to close the dura, to close the arachnoid, and so on. I will leave this to a future lecture. Here we have the opening in the midline, and the cyst is full of clear, like CSF-like fluid. And the more you decompress the cyst, the more CSF will come around because the cord is being decompressed. Now, evacuating the cyst led me to the wall, and here you can see the arachnoid anterior to the cord. So the whole cyst is extending from the posterior aspect to the anterior aspect. And my duty here is to excise it and excise it as a whole through this opening of the posterior sulcus without damaging the patient at all. If you know the pathology, if you know the histology, if you know the history of these cases, then you can diagnose them and treat them well. So here you can see the arachnoid in the anterior aspect of the cord. Okay, we'll finish here. Just one quick case and we'll be finished. Histopathology again showed the same thing like before. Cystic lesion lined by respiratory mucosa with hypocellular fibrous collagenous wall. Same thing. This is a patient post-operatively, no cyst, and he did well. Another case is a 19-year-old male patient with backache for 1 year, tenderness over the thoracic spine. Again, you can see the cyst inside the cord. We've done the surgery for him. And you can see here, opening the dura without opening the arachnoid. I always like to do that. I don't like to just open the arachnoid suddenly and get gush of CSF. So here you open the inner layer of the dura, and I always take a stitch in the dura and a stitch in the arachnoid, because once I want to close, I close them together. I identify the midline, I identify where the posterior sulcus is, I use the diamond knife, and I get into the cyst. Here it was not like the first case. First case was full of CSF. Here it was full with pus-like lesion, creamy pus-like lesion, as you can see. Again, the principles are the same: excision of the wall to avoid any recurrence. With this, I finish, and I thank you for your listening. I'm happy to take your comments and questions. John?
Oh, yeah, I'm sorry, Dr. Sabea. Okay, we had some technical issues. Okay, thank you very much. And we're going to open the panel to discussion. And hello, Omar. You want to start it off?
Hello, Dr. John. Hello, how are you?
Good, how you doing?
Thank you very much for very, very good, nice lecture.
Thank you.
Okay, very good. Hello, Victor.
From Dana Atlet.
Oh, okay, I'm sorry. Jabber has something to say. Hello, Jabber, welcome. You need to unmute, Jabber.
I am in the street, but I have followed the lecture, so I think it was very good lecture.
Thank you.
Thank you, Dr. Ibrahim. I'm out of hospital, out of my office, but I followed your lecture.
Thank you.
Thanks, Victor's in Mexico City.
Yes.
He's a frequent, you know Victor well. Okay, Jabber, sorry. Go ahead, Jabber.
Yeah, good morning here. It is very valuable lecture, and Dr. Ibrahim Spih is a childhood friend of mine.
Thank you.
From Payson.
Yes,
and
sure.
How are you?
How are you?
You know, recently I had a patient with some back pain, so we did MRI, and there was a cyst, accidental finding. I mean, there was no neuro symptoms. So she went to Mayo. My question to you is, are they always benign? The second question, is MRI enough to find out that this is a pure cyst, or there is underlying or background of tumor?
Sure.
The third question, if they are asymptomatic, do you process?
Right. Thank you, Jabber. Thank you, Jabber. It's so lovely for me to see you. Dr. Jabber has been my friend since we were in the school, in the high school, and we attended the medical school in Alexandria together. And then we joined the forces here in Jordan, coming back to our country. And then Dr. Jabber went to the States, and he specialized in medicine, internal medicine. And he's still a close friend of mine. And really, I'm happy, Jabber, to see you. Your question is related to these asymptomatic cysts that have been discovered accidentally. As a rule, I do not operate on a patient without symptoms, whatever the lesion is. It has to be symptomatic, and it has to be responsible for the symptoms of the patient. So if the patient is really asymptomatic, no signs, no symptoms, I will just follow him closely, because the natural history of these cysts is to grow. And what I do is not to only do MRI, but MRI, MRA, MRV according to the location, and even CT scan, even CT myelography. I go into various lab tests to make sure that this is not an abscess, this is not parasitic, etc., etc. But very good questions, Jabber. Thank you for your contribution.
All right, I will keep following you. You're doing very great. We are proud of you, Dr.
Thank you,
Ibrahim.
Jabber. Thank you very much.
All right, bye-bye.
Thank you. Bye-bye.
Very good. More comments or questions? Doctor, go ahead. Doctor. Go ahead.
Okay. Me?
Okay, who's going to go?
Dr. Abu
Omar.
Farsakh.
Dr. Hassan Farsakh is
Hassan.
our histopathologist. As I said, we've been together for decades. He knows me well inside out. I know him very well inside out. We know each other and we speak the same language. We have the same principles. We look for perfection. And Hassan is a perfectionist like myself, if I may say so. Hassan, please.
Thank you, Dr. Ibrahim, for very interesting and very excellent lecture that you delivered. I think it's a unique lecture. I want to comment on one thing we did together, me and Dr. Ibrahim, on cyst of the brain. We discovered a thing that is very interesting, that all cysts in the brain that are epithelial cysts, whether these are neuroenteric cysts, whether these Radcliffe cysts, colloid cyst, and craniopharyngioma, and all other cysts, they all have characteristically cytokeratin 19 strongly positive. And we did an abstract that is being published in the CAP 18 College of American Pathologists meeting. And it's really a novel discovery that cytokeratin 19 is present in all these epithelial cysts. The reason for that is that cytokeratin 19 is present in the fetal epithelial cysts that are present in the brain, and probably many of these cysts, they are there because of their epithelial origin, of their primitive origin.
Sure.
So I just want to comment because he showed the cytokeratin 19 in the neuroenteric cyst, and it was strongly positive. And this finding actually is not published in any of other journals before.
Absolutely.
Thank you, Dr. Ibrahim.
Thank you, Hassan, for your input. And as I said, we've been together for so many years now, and we have something between us like 15 publications on clinical and pathological, histopathological findings. So one should not stop research and should not stop publication. And this recent paper has been published in the Journal of American Pathology Academy. It's a very prestigious journal. Thank you, Hassan.
Very good. Okay. More comments or questions from the panelists?
Okay.
I think Omar.
Okay.
Go ahead, Omar.
Thank you. Hello, Dr. Subeh. Thank you very much to all. Dr. Subeh have these big cysts, intramedullary. Okay. Can we put tube shunt?
Right. In principle, I don't like. I believe in surgery, and I believe even if it is large.
Surgery, because too much symptom inside.
Still, you can remove as much as you can of the capsule, because that's much better than putting a shunt tube in. People stop doing this, putting shunts in the syrinx or syringo-subarachnoid space or cyst subarachnoid space, because it's gonna move, it's gonna block, etc., etc. So the same principle applies. Surgical excision, especially that those inside the parenchyma, inside the medulla, are extremely rare. So they're most likely are extramedullary and then just going inside. So if you catch part of the membrane, you can really peel it off.
I ask for nearly like cystic neuropharyngioma. You know, can we put this 3 centers at the ward?
No.
Tokyo, Nagasaki, Seoul. Or put reservoir because to eat like this thing. I see.
Right.
Okay, because we can't remove all.
Sure. I'm against putting Ommaya reservoir in a craniopharyngioma. Don't take my word for it. Take the word of big centers. Mayo Clinic, just last year.
Yes.
Ommaya reservoir is a palliative measure and should be left for the cases where you have no options whatsoever. Right? So don't put Ommaya reservoir. It's not a good option at all. It is the option of those who are weak in doing surgery for the craniopharyngiomas. Now, having said that, sometimes you have total defeat, that you cannot remove them. So it is palliative. And never put it if you think of sending them for radiotherapy or for surgery.
Sorry, for bleomycin, we inject inside the reservoir. What's the last studies? I don't know, because 20 years I booked study for 4 cases at Damascus City Center.
Sure.
Okay, like Javan, Tokyo.
Yes, yes. I'm against putting something inside the craniopharyngioma through the tube. It's gonna leak, and if it leaks, it's gonna cause major damage. At the same time, people are thinking of it as a palliative. It is not a standard treatment. The standard treatment of craniopharyngioma is radical excision, and so many papers showed us that total excision is possible. In the past, people used to say, no, you cannot excise craniopharyngioma because it is adjuvant, this and that. It is not correct. People have shown, especially from Argentina, especially from mid-Europe, Eastern Europe, that you can remove these and you can actually separate them. And if you get a beautiful postoperative MRI where the mammillary bodies are separated, well, there is no tumor. So I'm against Omeya reservoir, against shunts, against something injected.
I like your opinion. If you are, after surgery, less deficit, neurosurgical deficit is better to total resection or subtotal resection. It's better.
Right. Now, the idea is this. If I can achieve good results with radical excision, why should I go with partial excision? The thing is this. It is this mental exercise. What exactly is in here? What I'm planning for my patient. People would go in and they have planned already before they started. They will go for partial excision and send for radiotherapy. This is not correct. The only decision you can make about partial or complete dissection is intraoperative. So you go in with the intent, with the mental state, I want to remove it all. And if you find the plane of cleavage, you continue. If you can't, you stop. But you are going there with this intention to kill the tumor.
Yes. Your opinion, like UK strategy, the decision is very, very high before surgery. The decision is very important, too much important before the surgery. How to do? How good results and before and after the surgery.
Sure.
Thank you very much.
This is not my personal opinion. I looked at literature and
that
all the papers published since Yazergil in the 70s about his 130 cases of craniopharyngioma to big centers treating children. Radical excision is the mainstay, not partial resection radiotherapy. As if radiotherapy does not cause damage to the hypothalamus, as if chemotherapy does not cause damage to the hypothalamus, as if repeated surgery and Omeya reservoir does not. These are the causes of damage to the patient. That's why they live miserably, because people would go and do the limited thing because they don't have the experience.
Doctor, can I remember you? Remember you was the doctor, our father Yazergil. He tell us he is against radiology, radial therapy for any tumor. Repeat tumor without radial therapy. It's better for any patient.
Absolutely.
Yazergil and Mufti also, our professor, Mufti and Yazergil.
Sure.
I think on Syria also for many years, I take this opinion, no radial.
Yes. If there is need, you will give, but don't go as a front line of treatment. I'm going to go and take some of the tumor and send for the therapy. This is bad practice, and we should all fight it. We should all stand against it.
Like gamma knife, not good for all tumors.
Same thing. Radiation has its own side effects and complications. We should not be using it unless it is the last. Yeah.
Yes, Yaqub is a friend as a gamma knife at Jordan. I know him.
Sure.
So thank you very much for you.
Pleasure.
To all Jordanians, neurosurgeon, and to all who are here with us. Thank you very much for you.
Thank you very much. Thanks.
Thank you, Omar. Okay, any closing comments or questions from the panelists? Okay, Dr. Sabeh, I apologize. I messed up the Kahoot.
No problem.
So we'll have to do it next week.
Surely, no problem.
Sorry about that.
Dr. John.
Go ahead.
Dr. John, I need the passport to Kahoot, please. Can I take the passport?
Okay, we'll talk after. Okay, Omar.
Oh.
Okay, we'll talk after. Okay.
So, John, well, I'm going to miss the next week. I'm going to miss next Wednesday.
Yeah,
because
we're going
of
to try to
this-
televise that. Can you talk about that conference? Can
Yeah,
you talk about that
yes, of
conference?
course. I can send you the webinar banner
Okay.
once I agree with Kiki Torell, but it's going to be beginning of March. It's about complications in neurosurgery. Big panel from all over the world. I'm one of those presenting. So I will skip my usual lecture on Wednesday next, and we'll continue after that.
Okay, very good. We look
Dr.
forward to that. Omar, thank you very much, Omar. We'll talk after, okay? Okay, we'll talk after, okay?
What's up? Dr. Subeh,